In the previous lecture, we discussed that the sympathetic nervous system is the body's fight or flight system. We learned that whenever the body encounters a stressful or threatening situation, the sympathetic nervous system becomes activated and brings about several physiological changes such as an increase in heart rate, dilation of the airways, and redistribution of blood flow to vital organs. But the question is, how does the sympathetic nervous system actually produce these effects? To answer this, we discussed that sympathetic nerve endings release specific neurotransmitters, which then bind to receptors present on target organs and tissues, ultimately generating the desired physiological response. We have already covered the neurotransmitters synthesis and released by the adrenergic system. Now the next logical step is to understand the receptors on which these neurotransmitters act. Therefore, in this lecture, we will focus on the adrenergic receptors, their types, locations, signaling mechanisms, and the physiological effects they mediate throughout the body. However, before we start discussing each adrenergic receptor and its physiological effects in detail, I want you to keep this picture in mind. This represents a classic fight or flight situation and helps us visualize the various effects produced by activation of the sympathetic nervous system. In fact, we already discussed this in the introductory lecture on the autonomic nervous system. Now, as we move through the different receptor subtypes, I want you to continuously compare the effects produced by each receptor with the physiological changes that occur when a person is being chased by a big dog. By making these connections, you will find it much easier to understand and remember the actions of the different adrenergic receptors rather than trying to memorize them as isolated facts. The classification of adrenergic receptors into alpha and beta receptors comes from the classic experiments performed by Ahlqvist. He administered 3 adrenergic agonists, epinephrine, norepinephrine, and isoproterenol, which is a synthetic adrenergic agonist, to different tissues and observed how strongly each agonist stimulated them. He found that some receptors responded most strongly to epinephrine, followed by norepinephrine, and only weakly to isoproterenol. And these receptors were classified as alpha receptors. However, another group of receptors showed a completely different pattern. These receptors responded most strongly to isoproterenol, followed by epinephrine, and least strongly to norepinephrine. Since these response patterns were clearly different, Ahlqvist concluded that adrenergic receptors could be divided into 2 distinct families, which he named alpha receptors and beta receptors. Let's first talk about the alpha receptors. Alpha receptors are divided into 2 subtypes, alpha 1 and alpha 2 receptors. Alpha 1 receptors are mainly located on the postsynaptic membrane of effector organs and are responsible for many of the classic sympathetic effects, particularly smooth muscle contraction. At the cellular level, alpha 1 receptors are coupled to the GQ protein. When an agonist binds to the receptor, the GQ protein activates an enzyme called phospholipase C. Phospholipase C then generates 2 important second messengers, inositol triphosphate and diacylglycerol. Among these, IP3 increases the release of calcium from intracellular stores into the cytoplasm, while DAG activates protein kinase C. Together, these signaling pathways increase intracellular calcium levels and ultimately lead to smooth muscle contraction, which is the hallmark effect of alpha 1 receptor activation. Now, whenever we say that alpha 1 receptor activation causes smooth muscle contraction, the next question is, which smooth muscles are we talking about? One important example is the radial muscle of the iris. When alpha 1 receptors stimulate this muscle, it contracts and pulls the pupil outward, leading to pupil dilation. If you remember our previous discussion on muscarinic receptors, we learned that M3 receptors are located on the circular muscle of the iris. When these receptors are stimulated, the circular muscle contracts, causing miosis. However, it is important to note that this mydriasis occurs without cycloplegia, meaning that accommodation is not affected. In other words, the patient can still focus on near objects normally. This distinction is important because we already discussed that muscarinic antagonists also cause mydriasis, but in that case, the pupil dilation is accompanied by cycloplegia and blurred near vision. Therefore, remember that alpha-1 receptor activation causes mydriasis without affecting accommodation. To better understand this concept, you can go back and review our lecture on muscarinic receptors. And if we go back to our big picture, we can see during a fight or flight response, the pupils dilate to allow more light to enter the eyes, helping the person see better and react more quickly to the threat. Another important site where alpha-1 receptors are found is the vascular smooth muscle of arterioles and veins. When alpha-1 receptors on arterioles are stimulated, the arterioles constrict and their diameter becomes smaller. As the diameter decreases, blood finds it more difficult to flow through these vessels, which increases total peripheral resistance. If the pipes become narrower, the pump has to generate more pressure to push the same amount of fluid through them. This increased resistance against which the heart must pump is called afterload. Therefore, alpha-1 receptor stimulation increases afterload. In other words, the heart has to work harder to pump blood against this increased resistance. As a result, blood tends to remain in the arterial system for a longer period during diastole because it cannot easily flow through the constricted arterioles. Consequently, the pressure within the arteries during diastole increases, leading to an increase in diastolic blood pressure. Now, can we use this effect therapeutically? Definitely. Because alpha-1 receptor activation causes arteriolar vasoconstriction and raises blood pressure, alpha-1 agonists are particularly useful in patients with severe hypotension or shock. For instance, during anaphylactic shock, massive vasodilation leads to a significant drop in blood pressure. By stimulating alpha-1 receptors, we can constrict the blood vessels, increase vascular resistance, and raise blood pressure back toward normal levels. However, this effect must be used carefully. Excessive vasoconstriction can reduce blood flow to tissues and may lead to ischemia. In addition, because alpha-1 stimulation increases afterload, the heart has to work harder, which can be problematic in patients with underlying heart disease. At the same time, alpha-1 receptor stimulation also causes venoconstriction. Remember, veins act as capacitance vessels and contain most of the blood volume in the body. When veins constrict, more blood is pushed back toward the heart, increasing venous return and preload. According to the Frank-Starling law, a greater preload allows the heart to pump more forcefully, resulting in an increase in systolic blood pressure. So, when we put these effects together, alpha-1 receptor stimulation increases both systolic and diastolic blood pressure. Now let's think about pulse pressure, which is simply the difference between systolic and diastolic blood pressure. Since alpha-1 receptor stimulation raises both systolic and diastolic pressures by a similar amount, the difference between them remains largely unchanged. Therefore, pulse pressure does not change significantly with pure alpha-1 receptor stimulation. Since arterioles and veins are present throughout the body, alpha-1 receptor activation can also alter blood flow to various organs. For example, in the skin, alpha-1 mediated vasoconstriction reduces blood flow, making the skin appear pale during sympathetic activation. Similarly, in the gastrointestinal tract, vasoconstriction decreases blood flow because digestion is not a priority during a fight or flight response. In addition to the eye and blood vessels, alpha-1 receptors are also present on the sphincters of the gastrointestinal and genitourinary tracts. Since alpha-1 receptor activation generally causes smooth muscle contraction, stimulation of these receptors leads to contraction of the sphincters. For example, in the urinary tract, contraction of the bladder sphincter makes it more difficult for urine to pass, resulting in urinary retention. If we think about our fight or flight analogy, this makes sense because during a stressful situation, the body is focused on survival rather than urination or digestion. Clinically, this effect can sometimes be useful in the treatment of certain forms of urinary incontinence, where increasing sphincter tone helps prevent the leakage of urine. Another important location of alpha-1 receptors is the male reproductive tract, particularly in structures such as the vas deferens and epididymis. Stimulation of these receptors causes smooth muscle contraction and plays an important role in emission, which is the movement of semen into the urethra before ejaculation. From a clinical perspective, the more important point is not what happens when alpha-1 receptors are stimulated, but what happens when they are blocked. Alpha-1 blockers can interfere with this normal process and may lead to sexual side effects, such as problems with ejaculation. These adverse effects can be significant because some patients may become reluctant to continue taking the medication, resulting in poor compliance with treatment. Now let's move on to the alpha-2 receptor. Unlike alpha-1 receptors, which are mainly located on effector organs, alpha-2 receptors are found primarily on the presynaptic nerve terminal. Their main function is to provide negative feedback and regulate the release of norepinephrine. Mechanistically, alpha-2 receptors are coupled to the GI protein. Therefore, when these receptors are stimulated, they decrease intracellular cyclic AMP levels, which in turn inhibits both the synthesis and release of norepinephrine from the nerve terminal. As a result, less norepinephrine is available to stimulate alpha-1 receptors and other adrenergic receptors. If less norepinephrine is released, there will be less alpha-1 mediated vasoconstriction. Consequently, blood vessels tend to relax, leading to a decrease in blood pressure. This is why alpha-2 agonists such as clonidine are used as antihypertensive drugs. However, alpha-2 receptors are not found only on presynaptic nerve terminals. They are also present on platelets, where they promote platelet aggregation. Now, as we all know, platelets are non-innervated structures. They are not attached to sympathetic nerve terminals. Therefore, the question arises, which catecholamine acts on these platelet alpha-2 receptors? The answer is epinephrine. During a fight or flight response, the sympathetic nervous system not only releases norepinephrine from nerve endings, but also stimulates the adrenal medulla to release epinephrine into the bloodstream. This circulating epinephrine can then reach platelets and activate their alpha-2 receptors, leading to platelet aggregation. If we relate this to our fight or flight analogy, this effect makes perfect sense. In a dangerous situation, the body prepares not only to maintain blood pressure through alpha-1 mediated vasoconstriction by norepinephrine, but also to minimize blood loss in case an injury occurs. Therefore, circulating epinephrine promotes platelet aggregation, helping form a temporary clot and reducing the risk of excessive bleeding. Now, why is this clinically important? As we discussed, alpha-2 agonists are often used to lower blood pressure by reducing norepinephrine release. However, these drugs can also stimulate alpha-2 receptors on platelets, promoting platelet aggregation. Now, suppose a patient has hypertension. As we know, patients with long-standing hypertension are more prone to developing atherosclerotic plaques in their blood vessels, including the coronary arteries. In such a patient, increased platelet aggregation could potentially promote thrombus formation over an existing plaque. Therefore, although alpha-2 agonists are useful antihypertensive drugs, their ability to promote platelet aggregation should also be kept in mind as a potential adverse effect. Another important location of alpha-2 receptors is the beta cells of the pancreas. Remember that alpha-2 receptors are coupled to the GI protein, so their activation decreases cyclic AMP levels and inhibits insulin secretion. As a result, stimulation of alpha-2 receptors leads to reduced insulin release from the pancreas. Now let's think about the clinical significance of this effect. Suppose we use an alpha-2 agonist to treat a patient with hypertension. As we know, hypertension and diabetes frequently coexist, and many hypertensive patients either already have diabetes or are at high risk of developing it. In such a patient, activation of alpha-2 receptors on pancreatic beta cells will further suppress insulin secretion. As a result, blood glucose control may worsen. Therefore, when prescribing an alpha-2 agonist, we should keep in mind its potential to reduce insulin release, especially in patients who have diabetes along with hypertension. Now let's move on to the beta-1 receptors. Fortunately, beta-1 receptors are found mainly in just two important locations, the heart and the kidneys. Let's first focus on their effects in the heart. Within the heart, beta-1 receptors are present in the SA node, AV node, atria, and ventricles. Unlike the M2 muscarinic receptors that we discussed earlier, which are GI coupled and slow down cardiac activity, beta-1 receptors are GS coupled and increase cyclic AMP levels. Therefore, beta-1 receptor stimulation produces effects that are opposite to those of M2 receptors. As a result, stimulation of beta-1 receptors increases the heart rate, that is positive chronotropic effect, increases the conduction velocity through the AV node, positive dromotropic effect, and increases the force of cardiac contraction, positive inotropic effect. In simple terms, beta-1 receptor activation makes the heart beat faster, conduct impulses more rapidly, and contract more forcefully. So during a fight or flight response, the body needs to deliver more oxygen and nutrients to the muscles. To achieve this, the heart must pump faster and more forcefully, and beta-1 receptors help accomplish exactly that. As effect of beta-1 receptor stimulation is an increase in the force of cardiac contraction, also known as a positive inotropic effect. This means that the heart pumps more forcefully, which increases cardiac output. Clinically, this effect can be very useful in conditions such as cardiogenic shock, where the heart is unable to pump enough blood to meet the body's needs. However, this effect can also become problematic if beta-1 stimulation is excessive or prolonged. A heart that beats faster and contracts more forcefully requires more oxygen. Therefore, increased beta-1 activity raises the oxygen demand of the myocardium. In patients with angina or myocardial infarction, this increased oxygen demand may worsen the condition. For this reason, instead of stimulating beta-1 receptors, we often use beta blockers in these patients to reduce the workload and oxygen requirement of the heart. In addition to the heart, beta-1 receptors are also present on the juxtaglomerular cells of the kidney. When these receptors are stimulated, they increase the release of renin, thereby activating the renin-angiotensin-aldosterone system. So, during a fight or flight response, the body wants to maintain blood pressure and ensure adequate blood flow to vital organs. In the heart, beta-1 stimulation increases heart rate and contractility, thereby increasing cardiac output. At the same time, beta-1 stimulation in the kidney activates the RAS pathway, which helps maintain vascular tone and blood pressure. Together, these effects work in coordination to ensure adequate tissue perfusion during sympathetic activation. Now, let's move on to the beta-2 receptor. So, Before discussing the functions of beta 2 receptors, there is an important concept we need to understand. Beta 1 receptors have approximately equal affinity for epinephrine and norepinephrine, whereas beta 2 receptors have a much higher affinity for epinephrine than for norepinephrine. As a result, tissues that predominantly express beta 2 receptors are particularly responsive to circulating epinephrine released from the adrenal medulla. As epinephrine is primarily a hormone rather than a neurotransmitter, because it is released into the bloodstream by the adrenal medulla, and norepinephrine is mainly a neurotransmitter that is released from sympathetic nerve endings and acts locally. Therefore, many beta 2 receptors are essentially non-innervated, meaning they are not receive significant direct norepinephrine stimulation. Therefore, many beta 2 receptors are not directly activated by norepinephrine. Instead, they are designed to respond to circulating epinephrine. Now, listen carefully. Earlier, we discussed that alpha 1 receptors on blood vessels cause vasoconstriction. At first glance, this seems beneficial because vasoconstriction helps maintain blood pressure during a fight or flight response. However, let's think about this logically. As we discussed that during a stressful situation, the heart is working harder and faster because of beta 1 receptor stimulation. Naturally, a harder working heart requires more oxygen and nutrients, which are delivered through the coronary circulation. If all blood vessels were to constrict due to alpha 1 receptor activation, blood flow to the heart would decrease, potentially leading to ischemia or even a myocardial infarction. Similarly, if blood flow to the brain was significantly reduced during fight or flight response, the person could become dizzy or even lose consciousness. Clearly, we do not want these effects to occur during a fight or flight response. In fact, the whole purpose of sympathetic activation is to improve the body's ability to respond to danger, not to compromise the blood supply to vital organs. This is where beta 2 receptors become important. If we go back to our analogy, we can see that the body does not simply constrict all blood vessels. Instead, it produces a carefully coordinated response involving selective vasoconstriction and selective vasodilation. Blood flow is maintained or even increased to vital organs and tissues that are essential during an emergency, such as the heart, brain, and skeletal muscles. At the same time, blood flow is reduced to organs that are less important in that moment, such as the skin, gastrointestinal tract, and kidneys. That is why, during a stressful situation, the body releases both norepinephrine and epinephrine. While norepinephrine mainly produces alpha 1 mediated vasoconstriction, epinephrine activates beta 2 receptors and produces vasodilation in certain vascular beds, especially those supplying skeletal muscle, coronary circulation, brain, and the liver. In addition to blood vessels, beta 2 receptors are also present on several other smooth muscles in the body. One important example is the uterus. When beta 2 receptors are stimulated, the uterine smooth muscle relaxes, leading to a decrease in uterine contractions. This effect has an important clinical application. In cases of premature labor, beta 2 agonists can be used to relax the uterus and delay contractions, thereby helping to postpone delivery. Another very important location of beta 2 receptors is the bronchioles. When beta 2 receptors are stimulated, the smooth muscle present in the bronchioles relaxes, leading to bronchodilation. This effect is particularly important in patients with asthma, where narrowing of the airways makes breathing difficult. If we go back, this effect makes perfect sense. During a fight or flight response, the body needs more oxygen to support the increased activity of the heart and skeletal muscles. By dilating the bronchioles, beta 2 receptors allow more air to enter the lungs, improving oxygen delivery to the body. Mechanistically, beta 2 receptors are GS-coupled receptors. When activated, they increase intracellular cyclic AMP levels, and this increase in cyclic AMP leads to smooth muscle relaxation, which explains the vasodilation and bronchodilation produced by beta-2 receptor stimulation. In addition to their effects on smooth muscle, beta-2 receptors also play an important role in metabolism, particularly during a fight or flight response. Remember, in a stressful situation, the body needs a rapid supply of energy, especially for the brain and skeletal muscles. To meet this demand, epinephrine acting on beta-2 receptors stimulates the liver to increase both glycogenolysis and gluconeogenesis. Together, these processes increase blood glucose levels and ensure that vital tissues have an adequate supply of fuel during an emergency. At the same time, beta-2 receptor stimulation also promotes lipolysis, which breaks down stored fat into fatty acids. This is important because the energy released from fat metabolism helps support gluconeogenesis in the liver. In other words, the body is mobilizing all available energy stores to prepare for the increased demands of a fight or flight situation. In addition, beta-2 receptors can stimulate glycogenolysis in skeletal muscle. This provides a rapid source of energy for muscle contraction and may even contribute to the tremors sometimes seen with beta-2 agonists. Another important metabolic effect of beta-2 receptors is their action on the pancreatic beta cells. Since beta-2 receptors are GS coupled, their stimulation increases cyclic AMP levels and promotes insulin secretion. However, remember that pancreatic beta cells also contain alpha-2 receptors, which inhibit insulin release. So, who's gonna win? During sympathetic activation, the inhibitory alpha-2 effect generally predominates. Now, you may wonder why the body would want to suppress insulin during a fight or flight response. The reason is actually quite logical. During stress, the body needs to keep blood glucose levels high so that vital organs and working skeletal muscles have a readily available source of energy. If you watched our lecture on insulin resistance, you can clearly understand this concept. If insulin secretion were not suppressed, insulin would signal the liver to stop producing glucose and start storing glucose as glycogen. This would directly oppose the actions of epinephrine, which is trying to increase blood glucose through glycogenolysis and gluconeogenesis. In addition, insulin would promote glucose uptake by tissues such as adipose tissue and resting skeletal muscle, reducing the amount of glucose available in the circulation for working muscles. Therefore, by allowing the alpha-2 effect to dominate, the body keeps insulin levels relatively low during a fight or flight response. This allows the liver to continue producing and releasing glucose into the bloodstream while preventing unnecessary glucose uptake by less active tissues. As a result, more glucose remains available for the organs and muscles that need it most during an emergency.